I think it's important if you're starting an academic career, if you have those mentors in place, use them. And they don't have to be people that do the same thing you do. They could be people that practice a completely different area of urology. They could be people that aren't in urology or urogynecology at all. But there are folks that are great mentors, and I think there's been, in academia, there's been a huge emphasis on mentorship in the last 10, 20 years. And I would say, as a young person, I would say, use those folks as mentors. They can help you.
Hello, and welcome to our Winnovation Special Bonus Edition podcast. I'm your host, Dr. Kyle A. Richards. During our first episode of this season with Dr. Victor Nitti and Dr. Frank Lin, we had a really great discussion about overactive bladder, but we also touched on some very important topics, including how to build a urogynecology program and how to get providers excited about the urogyn field, amongst other things. Therefore, we're thrilled to release this bonus track featuring Dr. Nitti and Lin that we're calling Building Purposeful Passion for Urology. Bonus cuts. I hope you enjoy, and thanks for listening. When Dr. Nitti agreed to be on the program, I really wanted to pick his brain a little bit. You know, FPMRS, as is most of medicine, tends to be a team sport. And how did you go about building successful teams, Dr. Nitti, while you were at NYU and now while you're at UCLA?
So first of all, I think it starts with a feeling or a philosophy. And this is one that I own, and that is that the idea of creating the specialty of female pelvic medicine and reconstructive surgery, soon to be called urogynecology and pelvic reconstructive surgery. The idea was that this was going to take the best from gynecology and the best from urology. And it's not really, in my mind, the way it went for a lot of years. Yeah, there was some involvement of urologists in gynecology programs and vice versa. But I don't know that it really took the best of both worlds. In some institutions, there was competition amongst people. You know, sometimes you just have to leave your ego at the door to establish something that you really believe in. So at NYU, it was a little bit fortuitous. We had two separate divisions, a division in gynecology and a division in urology. And our division in gynecology lost its accreditation for lack of research. So I went to the chair of gynecology and said, how about we take the gynecologists into our program and we have a combined program? And at the time, they thought that was a good idea. So we started to establish a combined program. When I interviewed for the position at UCLA, it was a little bit different in that both the Department of Urology and the Department of Obstetrics and Gynecology had it in their mind to establish this division that they would both wholeheartedly support, with buy-in from both sides and buy-in from the practitioners. So that's what I was hired to establish. And, you know, I think the important things are to understand, yes, I have something to offer, but someone else has something different to offer that's equally important. You have to have a sense that we're all on the same team. We all work together, and we're working together for the benefit of our patients, for the benefit of our trainees, and for the benefit of research for the future. It takes a lot. It takes buy-in. And if you don't have that buy-in, it becomes very difficult because you can't help but have it become competitive. Oh, you know, you do this, but I want to do this, but I can't do this, and all that kind of stuff. But I think if you play off of everyone's strengths, you know, and we have 8 people in our division at UCLA, 4 urologists and 4 gynecologists. And most of us, you know, 80% of what we do is the same core stuff. And then 20% is something that one individual clearly has more experience with than the other individual. And we're going to use that person or those people to take care of certain conditions, or we're going to have them teach us how to be as good as they are. So I think it takes a lot of mutual respect, and it takes a lot of really leaving your ego at the door to establish a program like that. Now, when Frank started, he saw the growing pains of just starting to establish it. Things are very different now because at least our program at UCLA is now 5 years old. And I like to think we're one big happy family now, and I think we are.
And Frank, for you coming in here at UW as a new faculty member in 2020, having to start transition to practice is a big deal, and sort of building up your FPMRS practice. How has that gone, and what are some of the lessons maybe that you learned as you've transitioned now into year 3 of your practice?
Yeah, I walked into a very optimal situation. We have a multidisciplinary pelvic clinic here that was started by my partner, Dr. Sarah McCachran. So I got to walk into a clinic that had multi-specialty care, including physical therapists, urogynecologists, colorectal surgery, gastroenterology, and urology. And all of us, as Dr. Nitti mentioned, have our strengths and have other areas that we want to improve. And because of Dr. McCachran's work in creating that multidisciplinary clinic, I've been able to just plug myself right into that multidisciplinary clinic. In regards to what Dr. Nitti said about certain nuances of our practices, I've also been building some specialty areas that were sort of, no one had really wanted to step into those roles, but one of them was to work with the maternal fetal medicine surgeons for complex obstetrics in some of their placenta accreta spectrum cases. That and the transplant, pre-transplant evaluations for renal transplantation have been sort of like new things I never thought I'd be doing, and certainly not areas that I ever trained in residency or fellowship, that were sort of just sitting around ready for someone to pick up.
That's great. Yeah, I think you see these sort of openings as opportunities, and you got to step up to the plate. And I think, Frank, you've done a great job in your first 2 years here at University of Wisconsin. And then for our last section, I wanted to talk a little bit about mentorship and success in academia, or just in clinical practice, I guess, in general. Dr. Nitti, what do you think are some of your pearls? You've had a great, illustrious career that I've been really admiring for some time. But what are some of your pearls for building a successful academic practice and career?
Well, I think the first thing you have to realize is, in the place where you are, what kind of resources do you have, and what kind of things can you practically do? Now, if you're in a place where you can do anything and you have unlimited resources, whether that be from statistical help to a lab space if you want to do bench research, et cetera, you have to start out by being realistic in what you can accomplish in the situation that you're in. Now, if you're really early on, you could say, well, this is what I want to accomplish. I'm going to find a place that will allow me to do that. But if you're not so lucky to have that, you have to say, okay, here's the environment that I'm in. What can I do? What are some of the things I can investigate to launch my academic career? My second tip would be, and this worked for me, I don't know that it would work for everybody, but focus on something that we really don't know a whole lot about. For me, it was bladder outlet obstruction in women. It was just something I stumbled upon when I was a fellow, and I kind of took it to the next level. And, within 5 to 10 years, I'm one of the world's experts on the topic, mostly because nobody was an expert on the topic. And I took the time to learn it. So if you can find something that needs to be investigated, that interests you, I'm not saying go do something that you have no interest in, but I was sort of fascinated by this. And it was an area that was ripe for the picking because nobody was thinking about it. And of course, 30 years later, you say, well, gosh, are there any of those areas left? Yep, you'll find them. you'll find those areas. So I think that's an important thing. I didn't have a ton of mentorship other than the person who trained me, Shlomo Raz. He mentored me in fellowship, and if I had a question, I could ask it to him. But when I went to my institution, there was really no mentorship. Urology departments back in those days were 5, 6, 7 people. They weren't 30, 40 people like they are now. But I think it's important, if you're starting an academic career, if you have those mentors in place, use them. And they don't have to be people that do the same thing you do. They could be people that practice a completely different area of urology. They could be people that aren't in urology or urogynecology at all. But there are folks that are great mentors. And I think in academia, there's been a huge emphasis on mentorship in the last 10, 20 years. And I would say, as a young person, use those folks as mentors. They can help you. I didn't have that, but that's no reason why somebody else shouldn't have it.
No, I agree. I've been in practice for 9 years now, and I think mentorship is so critical as you get going in your young career. One of the things I've been thinking about more lately is recruitment of more urologists, young urologists, to go into FPMRS or urogynecology. I know you've had the pleasure of training lots of fellows over the years. So how do we recruit more young urologists into FPMRS?
Well, what I try to do when I talk to young people, and at UCLA it's easy because they can look at my practice or one of my partner's practices and see what it is. But not everybody realizes what it is. For me, it's extremely rewarding. And it's not just FPMRS. It's also everything to do with the way the lower urinary tract functions, neurogenic bladder, reconstructive surgery in men and women. So there's a lot of aspects, although some just like to focus in urogynecology. The message I give to young people is, it is particularly in the field of urology, more so than in gynecology, it is a specialty that's in high demand. It is a specialty that allows you to get a job and practice pretty much wherever you want, whether it be in a private practice, large group practice, hospital practice, academic practice. All those folks are looking for people in this field. My urology graduate fellows have their choice of what jobs they want, where they want to go. So I think that's important. Also, it's a lot of fun. And within the specialty, you have the ability to do crazy, difficult reconstructive things, or you have the ability to focus on bread and butter urogynecology or voiding dysfunction. So, and I think that as time goes on, that specialty certification will become more and more important because it's held by urologists and gynecologists. And in certain areas, people may, I don't know if this will happen, but may try and restrict what one can do based on board certifications. Again, I don't know that will happen, but it might happen. The rub is that it's 2 extra years of training. And lots of graduates nowadays don't want to do 2 extra years of training. So there's definitely a trade-off. And let's face it, in urology, there are plenty of jobs for graduates coming out of residency programs that without the need to do fellowship training. But I just try and tell residents what a rewarding career it's been for me, how much fun it can be, and the fact that at least today, there are many, many, many opportunities out there for all different kinds of jobs within the field.
Very well said. And I think, you've been a great ambassador and role model for the entire field, Dr. Nitti. So Dr. Lin, as a young urologist, then I'll give you the last word here. So what was it then that drew you to the field?
Yeah, great question. I think I was a PGY 3 resident at Arizona. I was actually on track to do an oncology fellowship, and I thought I would for sure be doing, full template RPL&Ds or something of the like. But ultimately was working with Dr. Christian Twiss, who is at the University of Arizona, who's actually a trainee under Dr. Niddy and also under Dr. Shlomo Raz, who was mentioned earlier. And he basically noticed that I worked well with that patient population in doing these quality of life surgeries and managing quality of life, prolapse or incontinence, overactive bladder, and just being able to think a little bit differently. That really struck me when I was in his clinic. And so I made the decision late in my residency course. I think early of my fourth year of residency, decided to switch to female pelvic medicine and reconstructive surgery. And my world has completely changed. And my course has completely changed for the better, I think. And Dr. Niddy is absolutely correct in mentioning that the job market is absolutely open for a urologist that's interested in doing FPMRS.
And I think another thing is, if you are a trainee that loves doing complicated surgery, there's certainly that opportunity within our specialty. And, Frank's a very talented surgeon, so he fits very well into the field because he can do the bread and butter stuff and he can do the big complex stuff. And I think if you like doing that, and not everybody likes it, but if you like doing that, there is an opportunity to challenge yourself and make some real big differences in the quality of life of patients that a lot of people just don't feel comfortable taking care of.
Well, it's great that Frank's on our team. So I'm definitely glad to have him as a partner and a friend and a colleague. And Vic, it's been great having this discussion. I've certainly learned a lot from the both of you. As a urologic oncologist, I always enjoy talking to my urogyn colleagues, and I really appreciate having both of you on the program. And we'll be signing off here. Have a good rest of your day, and thanks for tuning in. So long.
Winnovations is a production from the Department of Urology at the University of Wisconsin-Madison School of Medicine and Public Health. Thanks for listening.